Good morning, and all the panelists. Thank you for coming for this live course. So you already saw myself. I have Joe Sweeney as well as Parasuram and our fellow Bhavan. Nurse is Will and Alina. So if you can show the slides of live case number 1. So it's a 75-year-old male who actually presented to us with dyspnea and had a syncope also. So past medical history significant with hypertension. He has history of CKD and on hemodialysis, bladder cancer, hyperlipidemia, and aortic stenosis, which has been under surveillance. And echocardiogram always shows moderate to severe. Moderate to severe in the sense, if you see the gradient between 25 to 30 on the mean and peak about 25 or so, valve area we keep getting between 1.2, 1.3. Prior history of CVA. So other numbers would be his hemoglobin A1C of 5.9, LDL of 54 on just on statin. CRP is 0.5. That's what he has. And you see the medication which he's on and blood pressure has been controlled. So cath was done when he presented. He had distal left main with bifurcation involving both LAD circumflex. Prior stents with OM1 that was occluded. With moderate aortic stenosis, we thought he should get a heart team discussion for bypass as well as AVR since the syntax was high. He had heart team discussion, but due to the comorbidities, most of it was a patient on dialysis, prior CVA, and when the CT scan was done, that he had almost a porcelain aorta. So that's what surgeons do not like. So he came back to us for a complex PCI. So if you see the echocardiogram, like I mentioned, that his gradients are not high, but the valve score on the CT scan that he had was over 3,000, 3,400, which shows that it is actually severe. So here we are today with a man with, I'm going to show you the angiogram, and then we can have our discussion. This is where. So distal left main with ostial LAD actually will show better guide and about 50% ostial circumflex. And you see that OM2 that is totally occluded. That was another reason we actually got a surgical consultation. Though the LAD stent and the circ stent is patent, the small vessel stent is occluded. And then his RCA was okay. So right heart cath actually showed he had a PA pressures of over 80 and wedge was about 30. We got a gradient, invasive gradient of about 30 with the cardiac output. We actually not with the FIC was 5.4.
Wow, that's a complex case, all right.
Yeah.
So we have a fantastic panel here. That aortic valve, to me, on echo looked a lot worse than what you're telling me. Like, I just get really concerned. I hardly saw any opening of that aortic valve. John LaSala, you're here on the panel. That's the first thing that I'm thinking about in terms of proceeding without intervening on that valve. What do you think?
Yeah, I'm concerned as well. I share that same concern. But even though the EF is relatively preserved, we also have a very high PA pressure. So the potential for decompensation would be very rapid. I think what I would recommend, we'll see what Dr. Keeney chooses to do, but to use like a true flow balloon to give a mini valvuloplasty to give us a little margin for error. Mm-hmm. And then the bifurcation is not so complex that you're worried about wiring it and having prolonged ischemia. You could work from there as far as the PCI.
Would you be, and anyone, and the other part is the question of a support device in a case like this with such a high, PA pressure and right-sided pressures. What are you?
Yeah, I wouldn't disagree with that. I asked it as a counter argument that I think that the straightforwardness of the ostial circ and the LAD is such that your ischemic times would be relatively low.
All right, well, that's interesting. Let's hear from, Dr. Itchaporia is going to debate Greg Stone later on today about the use of protective devices. How would you approach this, Dr. Ichaporia?
Yeah, no, I agree. I think that I am worried about that aortic valve, and I think that, doing a valvuloplasty and then seeing what the hemodynamics are right after that. But, I certainly wouldn't rule it out. I mean, if you look at what I'm going to debate later, the pure data, again, this is about the CHIP score that Sharma said earlier, right? I mean, this person has a high CHIP score, so you would say that support would be in called for, but certainly there's no clear data because we're still waiting for those results. I have to stick to my...
Yeah, that's great. Yeah, Dr. Singh?
Yeah, no, I agree. I think these patients are the ones who have very, very poor reserve. I mean, these are the people who, even the groin, if they waggle, they spiral down and come back. So here, I think, if you're thinking about performing atherectomy, which I think, you probably will, I think support in here is, I think, important. It really is.
Dr. Bhatt?
I mean, it's the one thing to point out is that the CHIP score is nice, but they're all not weighted equally, I think. And the fact that you have a very high pulmonary pressure really pushes you in the direction of doing something prophylactically.
Dr. Bhatt?
Yeah, I agree with all the comments. From the history, it looked like the presenting symptoms were dyspnea exertion, and syncope was listed as well there. So I don't think the syncope is from the CAD. I think the dyspnea is probably also from the aortic valve, and the syncope, almost certainly, assuming it was real syncope, is from the aortic valve. So I'd be worried about that.
Any other comments, Dr. Moreno, all the way back there? Dr. Khanna?
I agree with the previous comments. My question was, the EDP was high, Anu, or?
Yeah, the PA pressures are very high, 80.
But it was a gradient. The transpulmonary gradient was high. Is it, or is just LVEDP super high?
Yeah, there was no transpulmonary diastolic gradient.
No transpulmonary gradient, but EDP was still high.
Okay.
24.
24.
Yeah, that was the wedge and that. Yeah.
Mm-hmm.
Dr. Khanna, before we go to
the...
Go ahead, Dr. Kinney, go ahead. Tell us what you're planning.
No, I thought you were done with all your
No, it's okay. Go ahead.
Panelists.
Go ahead, Dr.
No, I
Dr.
said we agreed with all the panelist discussion. Of course, you know that is calcified patient with end-stage renal disease. So we did decide we were going to do rotational atherectomy of the left main to LAD. So we did do some imaging. So we can quickly show both the imaging of left main to LAD as well as to CIRC. CIRC, I know, was moderate disease, but we still quickly show it the IVUS. So what we did was we did a balloon valvuloplasty, show the right coronary artery. And this was just a 20 millimeter balloon, which we did. And then we place an impeller. The question always comes is the same. Agree with what John Lasala was saying, that it's a simple lesion that we could do with this kind of an EF, that could we quickly do rotational atherectomy, go ahead and do either single stent, double stent strategy of the left main and circumflex. Only question is, with that kind of PA pressure, if there is a decompensation, then the resuscitation could be harder, especially when the patients are on dialysis. So despite EF being normal because of the EDP and high wedge pressure, he did have dialysis last night. All that we decided we will need some support when we're doing this bifurcation PCI with the atherectomy.
So I see the plan of atherectomy. Is it based on your angiographic or IVUS findings? I'm not clear that I'm seeing 360 degrees of arc of calcium. So maybe you can show that imaging to us so that we could be convinced that atherectomy is needed.
You can show the IVUS there?
Yeah, they are watching it.
That's the IVUS. That's exactly at the ostial.
okay.
LAD, go back. Yeah, there's a whole thing. I know.
LAD to left main, ostial LAD. And at level of the left main bifurcation, like 180, like eccentric calcium. MLD is like 1.7.
That's just a short lesion. Again, the point made by the panel, that is a short lesion. Why do you need a support? You can just do atherectomy. Now the question will come with this kind of stuff. It's a short lesion. Do you want to do atherectomy or directly go to IVL?
Yeah, that's what I was sort of thinking about. Based on the imaging, would you be choosing IVL as opposed to Dr. Khanna? How would you approach something like this, Parveen Khanna?
Yeah, first of all, this is a very interesting situation which we see in clinical practice, that we have coronary artery disease and severe aortic stenosis together, and the question becomes which one to treat first.
You can come back, Angel.
So here, since the PA pressures were so high, it appears that it is primarily because of the critical aortic stenosis that this PA pressures is reflected there. And it is not because of the CAD, because ejection fraction is okay. So reviving these patients, as Dr. Annapurna already said, that it will be very difficult if this patient crashes. So I think this approach of dilating this valve first, and maybe I would have even done a TAVI if the patient had started leaking at that time. So one has to be prepared with a backup plan that if this patient develops severe aortic regurgitation after the balloon dilatation, you have to be prepared for a valve implantation straight away, and then do the coronary intervention at that stage. However, usually what we do is, if we have a combined disease, typically what I do is I do the coronary first and then followed by
So I'm seeing that she's going in with a rotablator. I see the rotablator device. Does everyone agree with the rotational atherectomy? Or I personally think this is an easy slam dunk with the IVL balloon. Jazz?
Yeah, no, I think lithotripsy here is easy to cross. You can do lithotripsy here in a rotational atherectomy. The only thing in this scenario is, you can cause bradycardia and hemodynamic changes. And if you were to really perform atherectomy, it was hard to cross 360 degrees of calcium. Orbital may be better tolerated in this, where it is because of the way the mechanism, and it allows blood flow and less bradycardia, so orbital sometimes is better tolerated in these scenarios. But I think short lesion IVL, IVUS-guided IVL sizing should do the trick, I think.
But it looks like rotational atherectomy. Dr. Kinney, tell us, how does it feel to go through the lesion? And I saw that you stopped, sort of it jumped a little bit, the burr. Do you want to tell us the size of the burr and what you did?
Go back there. So the size of the burr, I picked 2.0. So if you see that, how do you pick the burr size based on imaging? It's a short lesion, and the diameter at that level where the calcium, eccentric calcium is like 1.7 we are getting. So we picked a 2.0, so we know some kind of atherectomy can happen. That's why it is, it's not, I would say, jump. It's a short lesion at that angle, probably. That's why the 2.0 burr, atherectomy was happening with the 2.0 burr. That is why we see that. That's one. Going back to the question of Jazz Singh, that could we have done IVL? So IVL, yes, I would agree. OA, can OA be done? Yes, OA can be done here. IVL, only thing about IVL is, since it is left main disease, doing even more than whatever number of seconds with this kind of hemodynamics with this guy, leaving the balloon there from left main to ostial LADV could be a little challenging. I know we have Impella on board, but something that we need to be concerned about. Otherwise, agree with the panel. Yes, ROTA, OA, IVL, anything could be done for this short lesion, ostial LAD. So what I have done is wired it with the run-through wire, and we're going to quickly image, going back to understand, did ROTA do anything? Otherwise, we will have a 4.0 balloon IVL ready if we need additional, atherectomy done there. Yeah, and you can show the IVUS of the circumflex also.
I think the point that you're trying to make about the IVL versus ROTA, we're going to discuss in the debate this afternoon. But basically, if you can cross it with IVL, that's what you do. If you can't get through, then you use atherectomy on top of that.
But then that means you open two things. You're a rich man.
We open up. No, I'm not a rich man, but
I checked the image.
In complex PCI, we open a lot of things.
No, I think imaging of the circ will be interesting. I think it's very, very important when you do bifurcations like that. Is always image both limbs just to understand really what's happening. So
coming to the ostial LAD and the distal left main.
Okay, show the ostial.
Yep, it's done. Yeah, so this is our tightest part. Yeah, now there's like a surface of the calcium is shaped. Good.
I think you can see a little, of course, OCT is the best to understand
the thickness,
how calcium modification has happened. But since it is left main involvement,
some dislap fiber also.
I think you can see a little cut, no? With
the we definitely see some breakage in the in the calcium.
What do you think, Kiski? Should I go there with IVL? I think it will open up now. I don't need to.
You did 2 over, so now the MLA did 2. But still, of course, there's 180 calcium at the level of the left main bifurcation.
Yes.
We cannot see the clear fracture by IVS. So, but anyway, it's well modified by the 2 overs.
So he's saying it's a good modification, which is good news. So
Yeah, I think it looks very nicely modified. I see the breakage in the calcium. I think you're fine to go with your balloon. Is that what you're doing next?
No, I'm wiring the circumflex, so we can decide what to do with the circumflex.
Yeah.
Show the imaging.
Sure. So as Dr. Kinney said, this is actually the osteocirc, and different from the LED, there is a calcified nodule protruding inside.
So you have
nodule.
This one is a nodule.
How you want to?
Yeah, the MLA of the osteocirc, the MLA is big, isn't it?
I want to cut.
Borderline.
Yes, too. Good point, Dr. Moreno.
It's like a, see that 4.4.
4.46.
You understand?
Yes.
Yeah.
But
you see, Pedro, if you think we stent across and then you have a nodule, and then if there is a plaque shift in this patient, then, so we have to make a decision now.
Correct.
So the question here is, do we stent both or do we go with provisional stenting? And I think from what I'm seeing or hearing, maybe anybody want to talk? I think less is more in a case like this. Already so much stent. I realize you're worried about your judgment is always overrules everything that we will say here. Dr. Kinney, obviously you're in charge of the patient. But this lumen doesn't look too compromised. There's a little bit of a calcium nodule. If you could get away with a provisional, I think that would be nice. But I don't know what everyone else is thinking. Dr. Khanna?
Yeah, I think, putting a protection wire is a reasonable approach here, and then doing a provisional stenting. And sometimes, about 20-30% times, I will even put a FFR wire once we have put the stent to make sure that whether we still really need to put the second stent or not. But certainly one stent is a better thing to do in this case.
Any other comments from
Coming
the
back,
panel?
Anu, the gradient across the aortic valve was too high before the balloon?
Yeah, it was 30. We are down to like 12 now, post-BAV. We did a 20 millimeter balloon, yes.
Yeah.
And
well,
the hemodynamics look
the
pretty
angiographic
good.
aspect of that ostium of the circ is always biased because of the cross-sectional. When you do the IVUS, you can tell. So I will probably go into the conservative approach here. I don't know what the rest of the people.
Any addition, Dr. Richaporia?
No, I agree. I also think that less is more in this.
Yeah. Dr. Kinney, I know you were thinking about 2 stents. Where do you stand now?
Yeah, it's just my question is, once we stent the left main to LAD, no matter what, that borderline, which is a real borderline lesion with the, see, if it was just a plaque, it would be okay. The calcium nodule is a very difficult one to take care later on, subsequently. Go up, yeah.
This is a 4015 NC.
I mean, according to the definition criteria, this is a high-risk bifurcation. The problem is the lumen is big and it's a nodule. And a lot of these stents you put in the thing, and the nodule usually comes through the stents also. So it's not really easy. If the lumen is big enough, I would probably do provisional here.
Anu, don't be biased. Do what you think.
Yeah, exactly. I mean, you should.
No,
you should.
Yeah, believe me, I really think that nodule will give us a problem later on. So we do have, I think we do the IVL of that nodule and just do mini crush. And I feel that once we stent it, circ is going to compromise.
Okay.
Now, for calcium nodule, for the audience or for the panelists, for calcium nodule, what works best?
Well, there's a lot of debate about that. I mean, people think that IVL doesn't work so well on calcified nodules, but it actually does fracture. It's just that it requires more pulses. And part of that is because the imaging, the emitter will be further away from the lesion, so it requires more pulses to do that. And you don't really have the reverberation that you have with more of a concentric calcified lesion, so you're not getting that augmentation that goes along with that. But it does fracture. It's just not going to fracture, multiple areas. It's going to, but it will fracture.
So for nodules, actually,
so Pedro,
yeah, go ahead.
Yeah, Pedro, we actually have submitted our analysis of imaging using OCT and IVUS both on the nodule. It will be presented, accepted in ESC, and we have a big calcium section where we'll be presenting our finding. So question is the same. Okay, go back to the nodule of the circumflex. Yeah. Go
Show
back
us
to
the IVUS
nodule
image
of
again.
So what I'm saying, if it is just the nodule, and then again you decide on the diameter of the circumference of the nodule, we would say, you see that it's less than 90.
We
And it's
don't
not
see
a
it.
lot
Can
of,
you
calcium.
display it for us? We don't see it on
Plate
ours.
IVUS?
We're not seeing the IVUS.
Yeah. So you see, actually it's not one, you have nodule from both sides. And that's one thing. Another thing is the calcium plate around is not a lot. So in this condition, I think you could do anything. But if you have thick circumferential calcium around, then you will have to do either rotational atherectomy or orbital atherectomy, and then maybe IVL on after that to take care of the nodule. We actually have another publication to say, is OA better or RA better when you have this nodule. The nodule, again, depends how much is protruding into the lumen and the diameter of the nodule, where we call it a mini nodule or massive nodule. 90 degree or more than 90 degree, yes.
The point about using two modalities on this, I mean, there's the registry data that's coming out about the frequency of this, and I mean, it turns out at least 15–20% of people that have atherectomy will have IVL on top of that.
I need
so
IVUS quickly
it's a common
after this.
strategy.
Yeah. And we're going to see what happens to the hemodynamics.
Yes.
You were worried about. You were worried about using that in the left main before,
Shockwave.
and here you are in the circumflex and obstructing.
Yes.
Yep. And I see that you are you're getting a little bit of a.
You see the hypotension?
Yep. We see it.
Look at the red one.
Yeah. With the IVL in place, and you need to keep it there.
Down. Go.
With the pulses and watch, and so therefore Impella comes in handy here.
Do you have it? Yeah.
So Dr. Moreno and I are talking about, Dr. Moreno and I were talking together about the fact that this gentleman's pulmonary hypertension seems to be out of proportion to the degree of either LV dysfunction and the degree of aortic stenosis, suggesting there's a secondary
Look at the hypotension.
Show the screen to us.
Yeah.
Complete in 5 minutes.
Okay, copy here. Yeah, we'll be done. So SS is saying go to the other side.
Okay.
Yeah, no, but after complete,
why don't we?
complete the case. No,
so tell us what your plan is.
We'll be done. Hold on. I want to show you the IVUS of the circumflex, and then we do 2 stent. At that time, you can go there. He's waiting for you. But look at this, Roxana. Look at the blood
Yes, we
pressure.
see it. We see it. Thank you. Let's look at it.
Yes. So 2, and I think we did agree. I'm changing it. Going back a little bit inside. Okay, good. One more, and then I think quick IVUS. We can see what the IVL did there.
What size is that?
We still see the blood pressure hasn't really recovered yet. You give it a little more chance.
Yeah, no, this is.
This is
now I want to be
amazing.
done.
Yeah,
I
these
think I'm
patients,
done.
they have very poor reserve, really. So
I'm
I
glad.
think
I
Impella
guess
is-
this one would be. I'm glad you have an Impella device there.
Yes. And also my concern, which I said earlier when we first started, IVL of both sides. So if you did not have Impella and we're doing IVL of distal left main, ostial LAD, ostial circ, always we see this. I'll do a quick IVUS to show what happened to the nodule. And then I think plan 2 stent strategy here.
Yeah. So just show us
Question
that, and
is,
then if you're
what
okay
should
with
be
this.
the size? Yeah, what should be the size of the IVL? Because they asked me what was a balloon. So if you see that, go back to that ostial circumflex where exactly the nodule is. And there the diameter, right? Diameter is around 4.
Yeah, I mean, sizing is critical in these
These are key,
nodules.
yeah.
2 things in IVL. Number 1 is sizing, and number 2 is balloon prep. The bigger the balloon, the harder its prep. And if it has bubbles, it doesn't work in nodules. You really have to be very methodical in prepping this balloon. So balloon prep and sizing is crucial in large vessels.
Yeah.
I completely agree with Jazz. Means imaging is critical when you're planning IVL.
Hey, let's keep seeing
Sometimes
what
we
you
see
got
that
there.
you're sort of in between.
yes.
Like if you have a 375 or 325, do I do a 3 or do I do a 4? should always size up because you're only going up to 4 atmospheres generally. So there's not going to be
Okay, now we are
worried
doing
about
IVUS, go live.
dissection that way.
Yeah.
Really like to see what this looks like, and if you're okay, we're going to go to the other room and then
Yes.
come back and see you.
Yeah, okay, go back and show what happened to our node. Yeah. Yes.
I feel like it looks somewhat similar.
You know, go back. There's fractures there. You'll see it on the top part. There was decent amount of fractures.
Sorry, but I'm deeply honest.
Yeah, look at that. It's actually cracked right there.
A little bit of a crack, yeah. That's it. I see it in right there at around 12 o'clock.
Once again, because you're
Give
not
us a
dealing,
stent.
you're not dealing with
OCT is a lot
circumferential.
better
Yeah,
here, by the
4020.
way, in showing us what's happening and how things are modified. It's harder to see with IVUS, but I think this is good. So now,
But the area is 7.5.
Dr. Kinney,
huh?
if you're okay, you're going to do a mini crush here. Is that right? And just tell us what.
I'm going to place the stent. We'll go up, and once we do that, you go other side. Dr. Sharma said he's giving me 1 more minute to place the stent.
Okay, 1
Yeah,
minute.
but
All right, that should be enough for you.
Important
This is,
that
420.
from 4.4 to 7.6 MLA is a great result for the IVL.
So, as you're doing that, I think what's amazing here is that hemodialysis patients, we have very, very little data on. And, these patients have just so many things going on with them and so little data on these patients on what to do and how to
you gave
approach
me
that.
the
And I always think that
side
this is an
branch first
area where
name.
we should have more focus of understanding because this number of these
right.
patients are going up. Dr. Bhatt, what do you think should be the approach?
took it
I mean,
out.
you see how much work there is, and now
This is
we have
40?
Darren McGuire
16.
and Bob Harrington here. Darren, how many papers have you published in Circulation? Dr. McGuire is our deputy editor of Circulation here, sitting here,
hold,
thinking, would you like some
16,
papers on
right?
hemodialysis patients?
Correct.
What do you think about what's going on here?
Sure, you can bring them on. Sunil Rao was just texting me what this patient really needs is a GLP-1 receptor agonist.
That's right. All right, is Sunil here? I don't know, I don't see him. Sunil, are you here? Hey, Sunil, come on up here so we could see you. Come on up to the top tables. Oh, good.
Side.
And so Dr. Bhatt?
I think the CKD patients are always tough. In some ways, it's a little bit easier for an interventional perspective once they're on hemodialysis, right? So you don't have to worry about contrast load as much, other than for the hemodynamics. I mean, this patient's LVDP's through the roof, so you do need to worry about that aspect
Right.
of contrast.
Can't see anything.
But I mean, it's been a long-standing
Ready?
debate. What do you do with CKD? Is surgery easier on those
I'm going to
patients?
go in, right? Side branch?
Is a percutaneous approach better?
But our surgeons are always saying no to these patients. I mean, you might
now it's not
think to yourself, oh, this man
Okay,
is
now that, yes,
75, has aortic valve, would have
Okay,
to
good.
have an aortic
Go
valve
up.
replacement and at
Side branch
least
going
3
up.
bypasses here. And they turned them down.
Hey,
Which is,
hey,
Yeah, that's the reality.
listen.
Side branch.
And these calcium in these patients is
Hold on.
unique too. They're both deep and superficial. So I think we have now technology that
Okay, go up.
actually addresses
Okay,
both,
go up. I thought I saw
improves the
it.
compliance, and I think the luminal gain that you get with lithotripsy in these patients is much, much better than even if you did rotational and just regular balloon. So I think we have modalities to treat these patients better too.
So you can see here the mini crush technique
Andrew
here.
can show the animation in the side of the mini crush.
Yeah.
Now again, same. Can we do mini crush? We can do culotte. We can do DK crush. Anything where we all say, become proficient, master a technique, and keep doing the same technique. So I'll take out some little die, and I'll take the side branch wire. Good. Okay, go up with the main now.
Yeah.
Also, Dr. Roxana,
Going up.
although there is so much data which is existing on DK crush, but I think, this is quite elegant in large vessels. Doing a left main bifurcation with a mini crush is quite reasonable, as Dr. Kinney also said, that if you start doing that and you have that, get accustomed to doing that, it works out very well.
Okay, so what I'm going to do is I will now go with the left main was about 5.0, right?
Yeah.
I think that's order. Yeah, so I'm going to do a pot of the left main recross and a kiss. and we'll show you the final IVUS results. You can go to Dr. Sharma now. He's waiting.
Okay, we'll go to Dr. Sharma, if that's okay with you, and we'll come back to you. Thank you, Dr.
Yes.
Kinney. Beautiful work. Thank you.
We did the mini crash.
Yeah.
Then we did the proximal optimization in the left main with 4.5 at 18 atmosphere. Recrossed multiple times, which I've never come across this situation. This is exactly what happens when you have an ostial nodule. Despite us doing the modification.
So you're relieved that you stented that.
I'm struggling to recross. Yeah. I'm struggling to recross.
You want to take the same one
for LED? So we have changed the wire.
3020 initial.
We can hear people from the other room talking.
Yeah, that would be
so
good.
So what happened is so that's always the question, when do you recross, before, after? So we recrossed after, and then we have 1O balloon. Finally, the 1O balloon crossed. Now I'm taking a 2O balloon into the circumflex. That is even anchor. So when you have, what are the points? So now you see the 2O balloon went in. So what are the things you need to do? Suppose you cannot recross, means take a balloon. The same thing. First thing you do is you recross into a different cell. Okay. So you are done your pot, recross. And if your balloon is not going, means ideally when it's left main, we will go with the high pressure balloon. For here, we wanted a 4O12 high pressure balloon. Would not go. So we went down to 2O. That is after, recrossing into multiple cell. Did not go. Then you anchor. So you take a balloon into the LAD. We do show the anchor. Go up. Go. So anchor means we will take, because it's already stented. You see a balloon in the LAD.
Yeah.
That way you're anchoring, the guide stays there, and you can show the animation of anchor. And now you have the balloon in the left main. You go up. Yeah. Yes.
What you're trying to do, this is really, it's the final kissing, and what she's having some trouble getting back, crossing in there because of that calcific nodule. And what she's doing is anchoring the balloon in the LAD to straddle this into the circumflex.
Right?
So really important to get that final kiss done. And so you see there's some technical challenges here that Dr. Kinney is overcoming by the different techniques for everyone to understand. Dr. Kinney, if you don't mind, because we're a little bit over,
you can go.
We need to go. You guys keep working and then show us the final results. Thank you so much. Fantastic 2 first cases, of course, as complex as it could be. Randomized to support versus not, both calcific, use of multiple calcific modification, and then, of course, imaging. Thank you. Thank you so much.